Welcome everyone to this Renal Association webinar. I'm really pleased for an exciting program that we've started on interventional nephrology. Mine is Dr. Saeed Ahmed and I will be chairing today's session. We have quite a packed program of short talks and long talks, and we hope to have a Q&A session at the end. There's a live chat feed for you to put questions in, and also please follow us on Twitter and our hashtag interventional nephrology. So to keep everything to time, I'm going to start with the first speaker, which is going to be myself. And this is going to be a talk on interventional nephrology as part of the Renal Association webinar program prior to the main event of UK Kidney Week this year. So thank you for your attention for the first talk. Thank you for the kind invitation to present on interventional nephrology. My name is Dr. Saeed Ahmed. I'm a consultant interventional nephrologist and clinical director at Medical Specialties at South Tyneside Sunderland Foundation Trust. During these talks, please follow us on Twitter handles SDIN at SDSFT and also at Rise at SDSFT, and there'll be a hashtag interventional nephrology. I would like to start with the background of interventional nephrology globally, and this starts back in 1999 when interventional nephrology was born out of the frustrations of timely and effective care for vascular access for established renal disease patients using an MDT approach by Steve Ash and Jerry Bethard. And the timeline progressed from there to 1999, where the Vascular Access Society of Europe also recognized interventional nephrology. And thereafter in 2000, the American Society of Diagnostic Interventional Nephrology was created. Thereafter in 2006, the International Society of Nephrology recognized interventional nephrology as a working group and also created training centers around the world. In 2012, the Association of Vascular Access and Interventional Renal Physicians of India created a successful program for developing nations called Avatar. And in 2014, the Spanish Society of Nephrology working group, Diagnostic Interventional Nephrology, was also created. 2015, the Asian Pacific Society of Dialysis Access also recognized interventional nephrology. So you can see a natural progression of a timeline with increasing recognition of international societies of interventional nephrology. In the UK, interventional nephrology variation as shown by GIRFT survey does exist. And GIRFT stands for Get It Right First Time, which is a UK initiative looking at variation. The reasons for this are variable, but probably fall into threefold. One is the renal curriculum is weak on interventional nephrology. The second is there's an unmet need in training or national training program. Other reasons are learning opportunities are variable and there's limited knowledge transfer from seniors to juniors. There's no dedicated jobs in interventional nephrology in the UK. And definitely in the past there's been a brain drain of interventional nephrologists who have been trained but unable to find jobs in the UK and therefore moved to overseas centres. And there are also the variations between DGH, nephrology and tertiary or quaternary centres. So these reasons probably have produced a difference in interventional nephrology in the UK. So our opportunity started when a consultant colleague, Dr. Anwar Siddiq, signposted me to this vascular access centre in the US to go and take a visit to look at how processes and techniques are being used for managing vascular access for our patients. So we took the opportunity to visit the vascular access centre run by Tom Vesely and Steve Bander in 2016. During that time period, I was a consultant almost 10 years into my tenure, and I visited the particular vascular access centre with my colleague Debbie Sweeney, who was a vascular access nurse at the time, and our registrar Dr. Clark. And we had a short visit but learnt an immense amount about process, about techniques in interventional nephrology and also efficiency of producing a service. So much so that subsequently in 2018, Dr. Clark then revisited for a fellowship, really to have a deep understanding of the processes and techniques of interventional nephrology and how to set up a service. And this was quite illuminating because this started a whole raft of work which led to, in 2019, establishing the Sunderland Diagnostic Interventional Nephrology Service. And subsequent talks will allude into the different types of service that we offer. But by 2019, we had 4 full-time consultants, all operating on a rota for interventional nephrology. And many of these will be presenting the agenda later on. And subsequent to that, the team has grown further, where we have brought in an element of education and multi-professional team working, and also with our international fellow, Dr. Haroon Ayub, who will be presenting later on. So the ESTIN team in 2019 progressed to having Dr. Sarah McCloskey and Dr. James Andrew as part of the team. The vision continues, and on this journey we hope that at some time in the future we'll have a UK diagnostic interventional program and curriculum. We have been performing and also highlighting vascular access interventional nephrology in many platforms, and in the UK Kidney Week 2019 we had a symposium chaired by myself on vascular access, and we had interventional nephrologists talking about their experiences and also some of the procedures such as fistuloplasty done by nephrologists, and also endorsement by the American Society of Diagnostic Interventional Nephrology on processes done, and in this case was Professor Arif Asif doing the representation. We subsequently moved on to a successful meeting held in Pakistan, where we presented our work and held a successful faculty workshops, and this is the faculty that was created for the workshops that were run in the Pakistan Society of Nephrology, and this included interventional nephrologists and trainers from around the world. We used the local teams and also the local facilities of laboratories in Lahore, Pakistan, to undertake simple procedures to be done safely in those environments, to show that this could be done anywhere in the world. Procedures that we undertook were tunnel dialysis catheter placement under fluoroscopy, tunnel dialysis catheter replacement and fibrin sheath angioplasty, and a brachiocephalic fistula angioplasty for just juxta-anastomotic stenosis, as shown here. The workshops were successful, and there were 6 of these, each one led by a mentor, and the attendees found these very helpful. They labelled the workshops from vein mapping, wire technology, fistuloplasty, tunnel neckline insertion on models, AVF needling techniques, and point-of-care ultrasound. The feedback was good to excellent for over 100 attendees. We then moved back to the Northeast. We run programs in the Northeast Training Program, and the Sunderland Diagnostic Interventional Nephrology Procedure course in 2019 was successfully run. And here we show that we had almost one-to-one trainers versus trainees, and we have a number of consultants here and trainees all learning about interventional nephrology, from models we use for kidney biopsy, native and transplant, to point-of-care ultrasound, and also models used for CVC and tunnel neckline access to use the Seldinger technique. And all of these received excellent feedback due to the hands-on nature and the mentorship received. Now, moving really swiftly onto a more global picture, curriculum regarding interventional nephrology do exist around the world, and this is one example on the NEFSAPS journal that we have in the United States. There also is the society we mentioned earlier, the American Society of Diagnostic Interventional Nephrology has a curriculum which is US-based. We have the AVATAR program mentioned earlier, also has a curriculum which is successful in the developing nations. And we have the International Society of Nephrology curriculum as well for developing nations. However, there is a niche in the market that exists where we do not have a UK specific curriculum for our governance structures until now. We hope to bring you in 2021 a postgraduate certification in interventional nephrology from Newcastle University. This is an exciting program. We hope to enlist our first students in the near future in September 2021. We are working with colleagues to create a faculty and the appropriate curriculum modules. So please look out for this in the future. The actual curriculum will be based on this model, where we will use a number of medical training stages, as in other curricula, to look at competencies in different procedures. Aligned with this would be the nursing competencies for nurses to assist in the Staff Nurse Associate Accreditation Programme 1 to 4, where staff nurses will be trained in competencies to assist the primary operator. And underpinning all of the procedure will be training in the renal interprofessional simulation and education, which is a vital part of the programme. So in summary, I've talked about interventional nephrology is now established around the world and soon to be established in the UK. Unmet need in training and variable opportunities do exist in the UK. UK interventional nephrology curriculum is soon to be launched, and please look out for this in the near future. I'd like to finish on this particular slide just to show knowledge transfer. So this is Fred Finkelstein, who taught Edwina Brown how to put PD catheters in, who taught myself how to put PD catheters in, and I'd like to see that I may have passed on some pearls of wisdom to Dr. Rauri Clark, who now also inserts PD catheters. So knowledge transfer has occurred horizontally, despite the vertical challenges in this setup. Thank you very much for your attention. I look forward to the question and answer session and discussion at the end of the programme. So thank you everyone, that was the first talk, and we're now going to proceed on to the next talk, which is going to be undertaken by Dr. Rauri Clark, who's one of my colleagues. I'd just like to say at this moment in time we have 166 attendees and 8 panelists, so we have a great attendance at this meeting and we can see the interest. Hopefully this will build throughout the meeting. Dr. Clark is the clinical lead in interventional nephrology and in the renal department, and he will share with his experience of what does an interventional nephrology service look like. So thank you very much, Dr. Clark.
Good afternoon, everyone. Thank you for joining us for this webinar. I'm Rauri Clark, one of the other consultants in Sunderland. In addressing the title of my talk, what does an interventional nephrology service look like? I will discuss the scope, the potential procedures that could be provided by interventional nephrology. I will discuss how a good service might provide each procedure and what the standards of care that we should be striving for are, and give an overview of our service and an idea of what resources we asked for when setting up our service. You'll see this diagram repeatedly this afternoon, but it is useful in giving an overview of procedures that can be offered by interventional nephrology. As you go higher up the pyramid, the technical skill required increases. It's not to say that every renal unit must have a nephrologist offering all of these procedures. Interventional nephrology is not an all-or-nothing concept. Every unit already offers some of these things, and it may be that some of these other things, such as point-of-care ultrasound, can be very easily incorporated alongside the existing service. It may also be that within a region, not every unit needs to have interventional nephrology, and that a hub and spoke model might work well. So the local geography will be important, but as will the strengths and weaknesses and the pressures and capacity on other related services within the organisation. What's the point of interventional nephrology though? Well, I think it's to support the mantra of right access, right patient, right time. And that's by multiple ways. It's of course in helping to maintain vascular access, but it's also to empower nephrologists and to grow the skills where there can be a dialogue between a nephrologist and a surgeon in helping to choose which vessel is used to make a fistula or whether a graft is used instead of a fistula. And it's about having the staff in place to help coordinate that pathway, and that's what our vascular access specialist nurses do. They also help our own procedures to run very smoothly, but they're the first port of call for our dialysis nurses in satellite and in the main dialysis unit whenever there are concerns about fistulas. So our nurses are able to be supported by us scanning fistulas, identifying suitable additional cannulation sites, advising on the best pattern of needling, including when to use buttonhole or when to use rope ladder. And interventional nephrology is a constant source of education and just reinforcing the fact that every individual involved with dialysis care needs to be able to recognise potential problems in a fistula early. We also coordinate the surveillance of fistulas, both when they're maturing and when they're in use. One of the good things about an interventional nephrology service would be being able to tailor the timetabling of procedures to patient convenience as well. And so having the capacity to do that is important. I think it's also crucial that there's a firm base in a day case area for assessment of patients and for recovery of patients, so that we're not using inpatient acute resources for semi-elective procedures. An example of this would be for renal biopsies. If I see a patient in a new patient clinic, I may think that they need to have a biopsy done within the next 1 to 2 weeks, and a good service will allow me to say what day next week would suit you to come in and have this biopsy done. For tunnel dialysis catheters, I think we're now at a stage when use of fluoroscopy for every procedure should be considered the standard of care. Otherwise, inevitably, a certain number of procedures will be abandoned just because a guide wire can't readily be advanced, or worse, the procedure is continued less safely, risking complications. As nephrologists, we need to embrace a wider range of equipment than we're used to so that we've got the right tools for the job. Some of these guide wires will make the difference between being able to complete a procedure and not. Each of these pieces of equipment obviously costs money. A guide wire may be £30 to £60, an angioplasty balloon is £100, but a tunnel dialysis kit is £200. So opening that and then throwing it away within 5 minutes because a guide wire can't be advanced is not cost effective either. And it goes without saying that clinical excellence is always the goal in all aspects of technique and asepsis. I'll delve into the importance of catheter position. A catheter tip positioned optimally within the right atrium makes a significant difference. It literally doubles the expected duration of function of that hemodialysis catheter. Even the tip being 1 centimetre too high at the junction between the superior vena cava and the right atrium will have a negative impact. And obviously that has a negative impact on costs of the service as well. Some subtleties in how the procedure is performed can also be significant for patients in terms of their comfort, the risk of aggravation of an exercise and secondary infection, and just the convenience of having a line in place in terms of choosing where would the patient like the exercise to be. The tunnelling of the catheter so that there's a smooth curve in the neck means that should that catheter need to be exchanged over a wire in the future, that can easily be done from the exit site rather than an incision at the base of the neck. When rewiring tunnel dialysis catheters, the commonest reason to need to do that in a catheter that's well positioned and that hasn't responded to thrombolytic locks is fibrin sheath, which has encased the catheter like a sausage skin. If the old catheter is removed, having advanced a wire down it, and then a new catheter inserted over that wire, the new catheter will just sit inside the existing fibrin sheath and therefore will develop dysfunction quite early. So some technique that disrupts that fibrin sheath is useful, and then the expected duration of function from that catheter is the same as a de novo line. So this is a very straightforward adjuvant to add into an existing nephrology service that already has fluoroscopy. I lead our peritoneal dialysis service, and I'm very keen that PD is an option for all patients as their first therapy without needing a bridge with emergency hemodialysis. Some patients inevitably will not be fit for a general anaesthetic procedure, and so someone in the organisation, be that a nephrologist or a surgeon, needs to be able to offer local anaesthetic catheter procedures and have the capacity to provide those at short notice. I think in the same way that we would always put our own dialysis catheters in for hemodialysis, we should also be able to do this for peritoneal dialysis catheter. And you'll hear this more about this later on this afternoon. Suffice to say, we've got a small peritoneal dialysis service, but it's doubled in size over the last 12 months. We've got an acute PD programme so that late presenting patients as an inpatient can start renal replacement therapy with PD. And because of that, our numbers have doubled in the last 12 months. Just as with hemodialysis access, involvement of the nephrologist in medical devices is really important. Understanding the difference between different brands of PD catheters, the different shapes of PD catheters, and also being actively involved in measure and marking mean that we're doing everything possible to improve the outcomes of our PD catheters. It needs to be accepted, though, that inserting a peritoneal dialysis catheter into an abdomen, the abdomen is a hostile environment for a foreign body. It's not always going to work, flows are not always going to be optimal. Maybe as much as 1 in 5 PD catheters are going to need to be repositioned or exchanged. And so we need to develop the skill set to be able to do that, to be able to fix the inevitable problems and not set ourselves up for failure. Actually, the main motivator for us to set up interventional nephrology was to improve the care we could offer for our patients with fistulas and grafts. So our service works as a rapid assessment and intervention clinic, so any concerns at all, the patient can be seen usually the same day. They can have point of care ultrasound performed by a nephrologist, and then if they need percutaneous intervention, we've got rapid access to that. Sometimes it's the same day, sometimes it's the next day. Of course, there are going to be times inevitably when the patient needs something that can't be offered by a nephrologist, such as surgical intervention or something of higher technical skill that needs an interventional radiologist. And so we need to have pathways in place to ensure that that is accessible. I mentioned surveillance briefly already. I think a surveillance program is important, whether it's clinical or whether it's monitoring flow, such as with transonics. And it will have an impact in the future demand for other procedures, however. Our patients are going to go through procedures which are at times uncomfortable. The angioplasty of a tight stenosis is an uncomfortable procedure to go through. We know that any stenosis that's angioplastied is going to recur, and the interval between recurrence of stenosis, and therefore the interval between intervention, is going to fall with ongoing time. So we need to make these procedures comfortable, but we need to ensure that that comfort is not at the expense of clinical risk. That has business case implications because we need to have a trained nurse there just for continuous patient monitoring, and we need to have equipment for continuous patient monitoring, including a transfer monitor. Things like this can easily be overlooked in terms of capital expenditure in a business case. A transfer monitor is £15,000, for instance. I'd like to contrast a couple of diagrams here. This chart shows our service before we started interventional nephrology. It's a diagram that shows a pre-dialysis patient having a fistula made, that fistula undergoing maturation, and then ultimately being used for dialysis. In orange are a couple of points in which there are concerns about the health of that fistula, and then going on from that, what we might need to do about that, which is usually to examine the patient, get an ultrasound scan, and then maybe get a fistulogram or angioplasty. Before, we needed to wait several weeks for the ultrasound scan to be performed in an outpatient, and then several more weeks for the fistulogram to be performed. Because we were admitting the patient to an acute nephrology bed for the recovery of their fistulogram, and because the interventional radiology department was under significant pressure with other often life-threatening interventions that were required, we had a high degree of cancellations on the day. Ultimately, that will lead to more access being abandoned because it's thrombosed and it's not suitable for thrombectomy. That can be contrasted with the current situation in which whenever there is clinical concern, the patient is assessed the same day, has an ultrasound done there and then there's rapid access to intervention. This should reduce the number of patients thrombosing and being abandoned, and this should help improve the vicious cycle that can otherwise occur, whereby prevalent dialysis patients are competing with pre-dialysis patients for theatre slots for access formation surgery. So what are the key elements of success in a service? Space. I think there needs to be a clear shift in what is and is not acceptable practice, and a total acceptance and buy-in from colleagues that nephrologists are going to need rooms in fluoroscopy. That may or may not require upfront capital expenditure. We need to have a day case area to support this service, and we need equipment, mainly ultrasound, but also the other medical devices that I've mentioned before. Ultrasound is so important. It can't replace clinical examination, and it shouldn't replace clinical examination. But it's so vital that every nephrology trainee, and I think every nurse involved in cannulating, is comfortable in using an ultrasound to assess the fistula. We need staff. Sometimes we can improvise a service because there is clinical need there without realising that we're really bending over backwards to deliver that care. And it's useful to step backwards and then plan what we need, seek that resource, and then start the service after that. There needs to be education of everyone involved in access care, and there needs to be, most importantly, buy-in from colleagues both within and without our specialty. And this can be difficult and needs a lot of conversations, I think, to explain that something that is a relatively new model in the UK is a safe and viable model. It will need support from other specialties, but where it is been done already, where it's well established, such as the United States, outcomes are very good, procedure safety rates are very good. So in Sunderland, these are the procedures that we perform. The numbers in brackets are roughly the annual numbers of each of these procedures, and that can be subsequently corrected for your population, knowing that we serve a population of 750,000 and have 300 dialysis patients. The Sunderland Diagnostic and Interventional Nephrology supports inpatient acute care as well as the kind of semi-elective outpatient care. So we have a treatment room in each of those areas. We've got fluoroscopy for 3 half sessions a week, and we have our day case area in the renal unit for this service to run out of. There is one nephrologist on call for intervention within hours, Monday to Friday, and that complements 4 other consultant roles, including the acute renal, the general medicine, the transplant role, and the acute kidney injury outreach role to our neighbouring hospitals. I mention that because this is a real way of reducing pressure on other aspects of the service. So if the acute on-call consultant is usually inundated by multiple referrals, at least now referrals about dysfunctional access in prevalent dialysis patients are going to another colleague. And that's really important in developing a sustainable service. The vascular access specialist nurse is in overall charge of this service and coordinating it all. And you can see here the staffing requirement for us to be able to provide safe recovery and safe sedation. So we've got capacity to recover a renal biopsy on the day case area any day of the week, Monday to Friday. At least under payment by results, a service of our size should be profit making. In considering points for a business case, there are 2 ways in which we can generate money with interventional nephrology. One is to help improve definitive vascular access rates and therefore get more money from specialist commissioners for each hemodialysis session performed. And there may be increased revenue from the commissioners if we do more procedures. It may be that in some units we won't be doing more procedures, it's just that procedures will be done by nephrology rather than by radiology, and that might be palatable, particularly if radiology is under demands on its capacity which can't be addressed by recruitment. The other aspects in the business case will be softer. At best they will be cost avoidance, or they will be patient experience, or quality of care, or organisation reputation factors. These are more difficult to quantify in money terms and even more difficult to realise in money terms. But they can be focused on reduced tunnel dialysis catheter rates, so reduced cost of central venous stenosis intervention and lengthy admissions with sepsis and deep-seated infection, reduced rates of fistula thrombosis requiring emergency theatre time for thrombectomy, reduced bed days for recovering patients. And this data is useful from the United States in the pre and post interventional nephrology eras. Bed day occupancy for access related issues fell significantly. So for our unit that would save around 450 bed days. Now that bed day will never materialise as a cost saving because it's equivalent to only 1.2 beds at any one point, and so we'll never close one bed, but it will improve perhaps patient flow or pressures on the service. It may be that interventional nephrology can be used to grow PD services and therefore reduce in-centre haemodialysis capacity, pressure, and it may mean that funding is not needed for capital investment in building a new in-centre haemodialysis facility. And I think any business case in an area like this, it is complicated and it does affect multiple other departments, and it needs to fully recognise the implications, both positively and negatively, on other departments. And it may be that locally that is a particular benefit and it really sways the success of a business case for interventional nephrology. I've mentioned already sustainable working for nephrologists, and in centres where nephrologists are part of acute medicine or general medicine like we are, then being able to recruit another nephrologist because they're attracted to work in a centre with interventional nephrology has a positive impact on acute medicine staffing as well. In planning service requirements, of course, local data will be best. Data from the literature is also helpful, and this was helpful for us. I had a feeling that we didn't perform enough fistulograms in our patients, and that might be why our definitive vascular access rate is lower than national target. And we were performing 0.5 fistulograms per patient with a fistula per year. In Canada, that's 1 per patient with a fistula per year, and in the US, it's 2. If introducing a flow surveillance program with transonic or equivalent, then that's likely to see an increase in referrals for ultrasound and fistulography. And it may be that that helps to swing the argument that nephrology need to be able to contribute to providing that capacity. This is a busy chart, but what I want to take away from it, it's a monthly breakdown of different procedures performed in interventional nephrology in our centre. What I want to take away from that is the variability of the number of procedures and the fact that we've got capacity to respond to variations in demand for each procedure. So you can see some months we've performed only 3 or 4 biopsies. In other months we've performed 20. There's no way that we could perform 20 biopsies in a single month if we were admitting each of those patients to the ward for recovery. You can also see the trend in growth of peritoneal dialysis catheter procedures and the trend in growth of ultrasound procedures over time. The other thing to mention is that some of this time has been during the coronavirus pandemic, and our activity has risen, not fallen during this time, because we were able to protect this as urgent work, and we were able to transfer some of this work from inpatient areas to this outpatient area. In summary, I think interventional nephrology lends itself to a treatment the same as cardiology or gastroenterology, as providing a viable service to work in a day case area. There's a wide range of scope of procedures, there's a varying level of skill required, but seeking funding to set up a day case area for current procedures being offered, and then a one-stop shop assessment of point of care ultrasound is probably the first step in starting a new service in another unit. I'm happy to take questions obviously at the end, but I'm also happy to be directly contacted by this email. Thank you.
So thank you very much, Dr. Clark. That was a very comprehensive and illuminating talk on the finances and setting up a service. I'd just like to point out we are trending well on social media. We've peaked at 190 attendance. So we are getting a lot of limelight on this particular topic. So I'd now like to introduce the next speaker. This is going to be Sister Debbie Sweeney and Sister Carol Foster, part of our, Carol Allan, part of our multi-professional team. And it's Sister Carol Allan who has done the talk preparation for multidisciplinary team working. So thank you very much, Carol.
Thank you for the opportunity to present on behalf of the excellent team. We have a weekly vascular access clinic with vascular surgeons. We have 5 vascular surgeons assisting us. The vascular surgeon sees patients that are assessed for fistula formation, fistula abandon, insertion of PD catheters and insertion of AV grafts. We have nurse review and medical dialysis staff. We look at exit sites, infected lines, We also do pre-assessments for all of our procedures. We have MDT meetings with all the renal consultants. We get referrals from them. Usually patients have to wait maybe 1-2 days before they have an appointment with us. We have safe sedation for patients who have PD catheter insertions and manipulation. Our staff are in the process of being trained for this. We have some staff trained, but the rest are waiting to be trained. We are also in the process of training staff for vein mapping. We have a study date already arranged for staff to do POCUS, so we can do ultrasound of fistulas and grafts for needling and any problems that are occurring while they're on dialysis as well. All of our referrals are made electronically via V6. They're made from the clinics, the renal ward, dialysis unit and satellite units. The Eston staff do all the booking in and booking out of the patients. We manage our own workload. We staff the unit according to our workload as well. This is our referral document. All the referrals are made to us via this. There is, at the side, there's all the interventions we do and the codes that need to be put in when making the referrals. This allows us to capture activity for the unit. This is a list of all the procedures that we do within the Eston department. Procedure times which the consultants do to take the procedure, and the recovery time of the patients while they're still with us in the Eston department. Patients are often double booked because they need line insertion and line removal as well. The most important part for us is the recovery time. We need a planned recovery time, so we have staff recovering patients in the department and also staff available to work with the consultants up in either fluoroscopy or the treatment room as well. We have to plan our off duty around this depending on what procedures we have in on a daily basis. We have learned by past experience that renal biopsies need to be done before 10 AM in the morning, as they need 8 hours recovery time minimum. And if they're done any later, it means our hourly day could go up to 10 to 12 hours, which is not really advisable. These slides are very similar. It just shows our diary and how much workload we have. There's no information in at the moment, obviously due to data protection, but as you can see on the left-hand side, it says how much activity that we do have in the blue shaded area. These are updated daily. We can some days start off with not much in at all, but by the end of the day, we have a full list because we have a quick referrals as well on a daily basis, and these are adapted into our workload. Yeah. This is the nurses. We're also capturing nursing activity as well as doctors' activity as well. That's why we use both resources. SNAP, that is Staff Nurse Accreditation Programme. This is for the staff nurses in Eston to ensure that in assisting the doctors with all the procedures that Eston do. Nurse POCUS. We've got the first in-house training programme next month run by Dr. Andrews. The first staff that's going to be trained to do this is the Band 6s in Eston, the Band 6s in the dialysis unit and the satellite unit. They will be trained to ultrasound fistulas and graft for cannulation. K-QUIC is a quality improvement project designed by the British Renal Society. Its aim is to improve cannulation of arteriovenous fistula and grafts based on best practice by preserving the lifespan of the existing AVF and AVG, improving patient experience to encourage patient to choose a fistula or a graft as their preferred type of vascular access. We collect data on vascular access data for a number of resources, for example, K-QUIP and the Renal Registry. Developing staff to be needling champions to promote principles of good needling technique for assessment of fistulas and grafts, and developing an assessment tool for all staff within the renal department to use. and daycare facilities in Eston. This first picture is our recovery bed. We have 3 of these beds in the department. We have a recovery chair as well. We have the daycare theatre, which you can see is set up for a procedure. We have all of monitoring equipment in there, and we also have a microscope in there as well. Endoscopy suite. The first picture shows the bench set up ready for the procedure. It also shows you the C-arm. Second picture shows the bench for the patient, the imaging equipment, the ultrasound machine. The third picture shows the monitoring equipment as well. Activity. This graph shows the activity totals within Eston. It shows the time scale along the bottom in month, and along the side the number of procedures that's being done. As you can see, Eston's activity has been on a steady increase since October 2019. As you can see, it reached a peak of nearly 140 procedures in July 2020. Summary. This team is our core principle. Managing patient progress to achieve sustained and predictable best outcomes. Achieving sustained quality improvement by data collection and application of results obtained from this data. Exciting new subspecialty roles for nursing and allied healthcare professionals. Eston Department has a fantastic working team. We all work well together. This has been fed back to us by patients' comments. Thank you for your attention. I'm looking forward to any questions at the discussion at the end of this programme.
So thank you very much for that talk, Carol. This excellent overview from the nursing perspective of what is required in an interventional nephrology service. We are now trending at 182 attendees, and we're getting good questions coming in the Q&A box. Please use the Q&A box to add your questions so we can use these at the end in the discussion area. You may need to change the volume of your settings at times due to the recording of some of these talks. However, moving swiftly on and trying to keep into time, I'm really pleased to announce the next speaker, Dr. Shalabh Srivastava. He's key to our organization for research and education, but also has a great skill in peritoneal dialysis catheters. And he's going to talk about peritoneal dialysis catheters and COVID-19. So thank you.
Thank you very much. I hope everyone can hear me nice and clear. The peritoneal dialysis catheter in the COVID-19 pandemic was my topic. My name is Shalabh Srivastava. I'm an interventional nephrologist and a clinical lecturer at my renal unit and at Newcastle University. As most of you all would know, chronic kidney disease and end-stage renal failure ultimately requires renal replacement therapy. That's in the form of hemodialysis, peritoneal dialysis, and transplantation. Hemodialysis is largely hospital-based. It's hemodialysis facility-based therapy. It's 3 times a week. Peritoneal dialysis is a home therapy. It is provided every day, and it's patient or carer dependent. And transplantation is a definitive therapy for eligible patients. Dialysis provision during a pandemic has some significant challenges. High-risk patients coming into a healthcare setting, staffing shortages due to staff sickness, increasing number of patients with acute kidney injury from COVID-19, and lack of intensive care capacity to provide renal replacement therapy were some of the challenges that we had faced. And I'll show you data for all of those. Advantages of peritoneal dialysis is that it's a home therapy. Ongoing delivery is not dependent on healthcare professionals largely. It can be provided in an acute setting without the need for expensive equipment, and it's an ideal resource for poor or remote settings. This is data from our own renal network, and you can see that in the month of April this year, we had rising case numbers of COVID-19 in our dialysis unit. This was also associated with a rising number of staff going off sick with COVID-19. You can see that there is increasing number of patients with COVID-19 as well as staff. And that posed some real challenges in providing renal replacement therapy. Dialysis access for peritoneal dialysis is key, and a nephrologist providing this dialysis access is extremely important, as I will show you. Peritoneal dialysis access can be a surgically done access as well as a medically done access or an interventional nephrologist done access. Surgical access is done for patients who have had previous abdominal surgeries or adhesions. It requires general anesthetic. It's often laparoscopic and sometimes open, and the catheter can be buried under the skin for future use. Patients with no previous abdominal surgeries generally have this catheter done by interventional nephrologists in our center. We use conscious sedation and local anesthetic. It is a percutaneous approach about which I will talk in a bit, and it can be buried under the skin for future use. The impact of peritoneal dialysis access and the technique is extremely important. As you can see from this paper from Pearl in 2014, a nephrologist doing an access means that the impact of patients and likelihood of utilization of PD is significantly improved. The use of PD catheter implantation by a variety of techniques is no different from this data, which was a large study published in 2015. And you can see that catheters done by the nephrologists, radiologists, open or laparoscopic techniques have similar outcomes. Technique survival is also similar in both surgically and nephrologist inserted catheters, again from this study in 2001. The medical insertion of a peritoneal dialysis catheter in our unit is done under fluoroscopy, and there are some significant advantages. I will take you through some of the key steps in the insertion of the peritoneal dialysis catheter. We use a C-arm on the extreme left. A small incision is made horizontally under the umbilicus, and we use fluoroscopy to make sure that we haven't inserted our Seldinger needle into the bowel by using contrast, and I'll show you some better pictures in the next slide. We use the Seldinger wire to get to the pelvic cavity, dilate the tract, and then insert a catheter via a peel-away sheath. The catheter can then be tunneled under the skin, and in the final picture here, you can see that the catheter is actually buried under the skin. It can be used immediately or buried for future use. Fluoroscopy has some significant advantages in helping insert this catheter. You can see that the wire placement is confirmed with fluoroscopy. You can see that the contrast is outside the bowel, and this helps us in making sure that there is no bowel injury. The split sheath catheter and the dilator is in the pelvic cavity. And finally, the catheter placement is confirmed by fluoroscopy on the table. As you've seen in other slides before, during the pandemic, we inserted more catheters and our activity increased. This helped us in giving resilience to our PD program. During the pandemic, we increased our patients' population on peritoneal dialysis by 35%. There were no COVID-19 positive patients in our PD population as opposed to the hemodialysis population, which you saw earlier. And we had the ability to provide access to acute peritoneal dialysis. In summary, percutaneous peritoneal dialysis catheter insertion is a safe and effective technique. It allows for access to acute PD. It can be delivered in a resource-poor setting or when access to elective theatre slots is not available, especially during the COVID-19 pandemic when we lost a lot of our surgical capacity. In the current scenario of an ongoing pandemic, it provides us with options and resilience in providing dialysis for our patients. I have acknowledgements for my trust, the Sunderland Diagnostic and Interventional Nephrology team, Newcastle and Sunderland Universities, Renal Association and British Renal Society, who have helped organize this program. We will take questions at the end of the presentations. Thank you very much.
Thank you very much, Shalabh. A great overview of what has happened in our unit regarding PD catheters. We are still trending on high numbers with people attending, and we are getting good questions in from the Q&A section. Please add them in. Some of those are being answered already, and we'll continue to do that. So we're really gearing up to a nice discussion at the end. So I'd like to now introduce our next colleague, who is actually a recent appointee, which is Dr. James Andrews, who's going to talk about point-of-care ultrasound, or POCUS, as this is now a growing field in general medicine and more so in renal medicine as well. So thank you very much, James.
Hi, my name is Dr. James Andrews. I'm a renal consultant, and I've been asked to give a 10-minute talk into point-of-care ultrasound and how it's relevant to nephrology. So before I do that, I need to give you a little bit of the backstory. In late 2018, when I arrived here as a final year registrar, we'd just lost another vascular ultrasonographer. Sunderland Royal had just been made the local vascular hub, and these factors combined meant we had much reduced capacity for ultrasound scanning and subsequent interventional procedures. There was a significant waiting time associated with routine planned work, such as vein mapping, and this led to further pressures when patients on the chronic hemodialysis program had problems with fistula dysfunction. All of these factors created a need for the situation to change. At this time, I had received very basic ultrasound tutelage during my training, which was limited to being able to turn the machine on and use it to identify with middling confidence the thing I was sticking a needle into, be that a vein or a kidney as appropriate. I'd received no formal education in the physics of ultrasound, and it all seemed like a bit of a dark art. A friend and now consultant colleague persuaded me to do an acute medical ultrasound course, which gave me the grounding in physics and a framework for assessments, which made the things I've been doing for the last 5 years suddenly pop into focus and make sense. At this time, the Eston business case was being approved, and I was given the opportunity, mostly I think as a way of getting me to be quiet, to lead on the ultrasound aspect, develop protocols and integrate this into the rest of the service, whilst ensuring we have buy-in from other specialities. In my acting up period, I was asked to set up and run the Trust Point-of-Care Ultrasound faculty, and we now have members from the medical director to the acute medicine department, radiology department, the new local Sunderland University Medical School, emergency department, and also representatives from care in the community. So that's the context. So for the remainder of the talk, I'll be covering what point-of-care ultrasound is, what's the evidence base and training requirements, what's the relevance to nephrology, what we're currently using it for here, and the potential future plans we have. So, ultrasound. The first point to make is that it's different to a formal or consultative ultrasound where the patient is sent to radiology for an ultrasonographer or radiologist to assess. I like this image and use it a lot as it's an excellent representation of the standard model of care. In the standard model, the patient is seen by a clinician and a test is required. The test is done in a different department and sometimes needs to be interpreted before the result is put on a system. There are potential delays at each step, and sometimes a number of days can pass whilst you're waiting for the result. In that time, a generic management plan aimed at multiple pathologies is often started whilst waiting for the results. Now, point of care gives you the advantage of being able to answer a specific question in the moment by the bedside and then act upon that result, such as, is there hydronephrosis, is there an obstructive cause to a kidney injury, or is there a pleural effusion as a cause of their dyspnea that needs a drain, or is there ascites as a cause of their abdominal distension? Now, it's at this point that I'm talking that some people can get defensive about their examination skills or potentially worried about the time investment it will take to learn a new skill. I'm hopefully going to persuade you that this is going to make you better as a clinician and streamline the care for your patients. There absolutely is a learning curve for ultrasound, but there was a learning curve when we all learned how to do physical examinations or interpret ECGs. I would argue that this is something I would want to be a standard of care in the future for certain conditions. Now, as you begin to look into the evidence around point-of-care ultrasound, you realise just how long it's been around for and how many people have been involved in its development. We owe a lot to our colleagues in emergency medicine who really went and developed this field and set up a lot of the preliminary studies and work. The only 2 points I'm going to highlight relevant to the evidence base. There's one paper from the American Journal of Cardiology from 2005. This compared medical students against board-certified cardiology attendings in the US. with 61 patients who presented with clinically significant cardiac disease. These patients underwent a formal echo and then were assessed independently by a cardiology consultant or a medical student. The medical student had a handheld ultrasound scanner and 18 hours of training with said device. Who'd you put your money on? The established professionals and their clinical assessments with, in some cases, decades of experience, or the medical student? As you can tell, because this is a talk about point-of-care ultrasound, the medical students had higher sensitivity and specificity compared to the consultants. Displayed on the side, we have the relative sensitivities for both groups, with the medical students on the left. The point I'm hopefully making here is not that physical examination is useless, although I'm not really convinced I've ever heard a diastolic murmur outside of a PACES course, but that this is a relatively small time investment for a potentially big return on the student's time. The point I'm going to make about evidence is that in autumn of 2019, the Royal College of Radiology released a joint position statement with the Society of Acute Medicine supporting the use of point-of-care ultrasound, and that they should assist wherever practical in helping train people to do so. They have specifically recognised the famous course, which has been developed by the Society of Acute Medicine. This is a nationally accredited course, and the one that I did, and the training gives you the ability to do long ultrasonography, look for free fluid in the abdomen, hypernephrosis, and a bladder assessment, alongside a DVT rule-in scan. I think this is a wonderful introductory course into the world of point-of-care ultrasound, and we were due to run our first famous course here in a fortnight, but had to cancel due to the worsening coronavirus situation. Moving on to renal training, which currently has no formal ultrasound accreditation. This is at odds to the Society of Acute Medicine, who I believe is due to endorse the famous curriculum as mandatory training for their trainees in the coming years. In our region, as part of the STIM training course, I give a talk on basic ultrasound physics, and from 2021, with support of the local trainee program director, we were planning on offering all the renal trainees in the region free famous training. Consultants from other hospitals have very helpfully been willing and interested in becoming supervisors, but however, in the current situation with coronavirus, this may delay us slightly. Ideally, as a next step, I'd like to see ultrasound integrated onto renal training in some capacity, similar to how it's being used in acute medicine and emergency medicine. I think given that we're already using it in our day-to-day practice for procedures, nephrologists are well placed to be able to do this. So now I'm going to pivot to how I find point-of-care ultrasound useful in my day-to-day practice as a nephrologist. Is a fairly standard tale to many. So it's Friday afternoon. A patient has just been admitted through the acute medical unit with a creatinine of 917, a potassium 6.2. They've had a catheter placed a couple of hours ago. They're oligoanuric. They get on the renal ward at about 7 o'clock at night, and you're trying to decide if they need to have dialysis before you go home for the evening, bearing in mind it's usually a 24-hour on call. So at the point where I assessed the patient, and this is a real patient from a few months ago, I ultrasounded them and found that they only had one kidney. The kidney itself was obstructed, and then I referred him across to our colleagues in urology who did a CTKB that showed a stone in the distal ureter that then had urological intervention, meaning that this gentleman didn't need to have acute dialysis, but instead got a definitive urological procedure with medical management of his electrolyte abnormalities before his renal function spontaneously improved. So how else are we using point-of-care ultrasound in interventional nephrology? This slide illustrates a vein mapping that we've done for a patient who had difficult cannulation, who was referred in. This is something that our nurses are getting increasingly comfortable with, and we're now teaching them how to do cannulation under ultrasound in difficult cases. Been fortunate enough to acquire a significant investment of funds to be able to purchase some new machines, and what you can see pictured here is a point-of-care ultrasound machine that plugs into your phone, turning that into the ultrasound machine. This is a number of advantages, apart from the obvious portability. From an infection control point of view, it's actually much safer to use these than a standard cart-based machine, as you can clean them much more effectively in contingencies such as coronavirus. This particular device also has got a number of novel applications, including telemedicine. You can see a colleague of mine scanning a transplant patient's abdomen. They were unable to get adequate views of the transplant, and so contacted me at home when I was having my Sunday dinner, and I was able to call in and both see the direct real-time ultrasound images that were being generated, but also see exactly how they're holding the probe, as this particular machine, the Butterfly IQ, is able to use the phone's front camera to be able to show exactly where the person is scanning. So where do we see point-of-care ultrasound in the future? Now, as you can see from this slide, which I'm contractually obligated to mention, point-of-care ultrasound sits firmly within the framework of the interventional nephrology curriculum, and in the future, as I've mentioned, I hope that it will be more broadly accepted into renal training. As my colleague Dr. McCloskey mentions, we have the ultrasound simulator trainer, and this has been invaluable and has had excellent feedback from students, introducing them into point-of-care ultrasound and also being able to display simultaneously normal versus abnormal pathology with the flick of a button. Like all of you, I'm in far too many WhatsApp groups, and one of the ones that I've set up is a point-of-care ultrasound in nephrology group for our regional renal trainees. There is monthly ultrasound teaching available from the point-of-care ultrasound in nephrology group in America, which we Skype into. And apart from the occasional Zoom bomb, it's been invaluable in terms of teaching and training. And I hope that this is something that we can integrate into our own training locally in the future. So in summary, and this is my final slide, point-of-care ultrasound development has been slightly fortuitous in that it's been the right place, the right time. I believe it's something that we will see our trainees doing more and more in the future, and to be able to supervise them adequately, we need to invest the time and resources now. And finally, that it's a great tool for education. So many thanks, and I look forward to answering any questions at the end.
So thank you very much, Dr. James Andrews. That was an excellent exposition of point-of-care ultrasound, which I do think is a growing field. We now move on, part of the agenda, into talking about education. And also we're going to have a talk on renal interdisciplinary simulation and education by Dr. Sarah McCloskey, who is going to hopefully be our new appointee in the near future. But today she's talking about renal interprofessional simulation and education. So thank you very much, Sarah.
Our simulation and education programme underpins and supports the ESTEN curriculum and has allowed the Centre to lead in procedural training and interdisciplinary simulation. We have a number of elements to our educational programme, and I'll take you through these each in turn today. Our 5-day interventional service allows us to provide supervised training and procedural competencies for renal registrars, including the procedures you've heard talk about today, such as central venous access, biopsy and PD catheter insertion. We have several part-test trainers that allow our trainees to build their confidence before moving on to performing the procedure on real patients under supervision. But the educational advantage of having a physician-led interventional service is the huge volume of experience that trainees get whilst they're in our unit. We currently host the Regional Procedural Induction Day for new and junior renal trainees. This is a collaboration between the renal units in the North East to provide hands-on experience for newly appointed renal trainees. We use hybrid models to simulate kidneys for biopsy and organic materials to help recreate the tactile element of procedures, allowing the trainees to really get to grips with how a procedure would progress. Using simulation in this way has been shown consistently to improve trainees' confidence and reduce medical errors. The renal trainees who rotate into our unit are also taught how to perform fistula ultrasounds for both maturation and diagnostic purposes. And as Dr. Andrews has explained, we are in the process of teaching our dialysis nurses to use ultrasound to assist in fistula cannulation, with a view to also progressing to diagnostic scanning. This is the Bodyworks Eve ultrasound simulator, which you've already seen. The mannequin allows the user to perform lung and abdominal ultrasound along with echocardiography, and includes a number of self-directed training modules that takes the user through normal clinical findings along with a range of pathologies. This model has been invaluable to our training during the COVID-19 pandemic, allowing us to continue to teach ultrasound without the need for patient interaction and potential COVID exposure. Medical simulation is the experiential learning that every healthcare professional needs but might not always engage in during real-life patient care. It provides a safe and supportive environment where learners can develop their skills without compromise to patient safety, and has been proven not only to reduce medical errors and the associated costs, but also improving outcomes in patient care. It allows the participants to gain experience in and exposure to potential high-risk or rare clinical situations that might not be frequently encountered on a day-to-day basis, such as anaphylaxis, critically ill patients, and cardiac arrest. Simulation also allows the participants to develop those skills which are not easily taught and measured, but are vital to safe and effective care, such as teamworking and communication skills. The true advantage is that it can be used to assess individuals on their own, but it can also assess a whole multidisciplinary team and the way they interact and behave with each other in order to collectively learn and improve patient safety. We have a portfolio of clinical scenarios that deal with various medical emergencies on hemodialysis, such as tunnel neckline sepsis, anaphylactic reactions, gastrointestinal bleeding, and chest pain. The participants are given a short vignette and then asked to assess and interact with the mannequin as they would with a patient in real life. The scenarios progress with the patient either improving or deteriorating depending on how well the team have managed the clinical condition. Following the scenarios, the team and any spectators are taken through a debrief process, which not only includes discussing the clinical learning points, but also the non-technical aspects of their management, including teamworking, communication, and situational awareness. It's this debrief where most of the learning actually occurs, with the team identifying what went well and what could be improved in the future. Well-developed senior nurse and medical faculty who are able to independently deliver and debrief these scenarios to allow us flexibility in how we deliver our programme. We have adapted our mannequins to include a functional forearm graft which can be needled, or a tunnel neckline which is also fully functional. The mannequin can then be attached and commenced on dialysis, and it allows the scenario participants to run through clinical tasks such as washing back and disconnecting the patient in real time, adding an additional element of realism to the scenarios as they play out. We deliver the programme in situ on the dialysis unit. This allows the staff to not only fully immerse themselves in their usual working environment, but also helps us to identify latent issues that could potentially impact upon patient care, such as misplaced or malfunctioning equipment, or logistical issues that could be improved. Our nursing and healthcare assistant staff felt that they had a significant increase in their confidence in various aspects of care, such as those shown here, and others such as being aware of the big picture, speaking up if there was a clinical issue, and taking on a leadership role. The clinical impact of simulation training can be very difficult to measure, as there are often too many confounding variables that affect patient care. However, as a surrogate marker, we ask our staff to complete a clinical knowledge test comprised of 15 MCQs before and after the training session. And as you can see, there is an obvious improvement in scores following the training for all participants on this particular session. The programme has been particularly effective in improving the confidence of our dialysis technicians in our satellite units, where the medical staff are not immediately accessible, and the sessions are now incorporated into our induction programme for junior doctors rotating into the department, some of whom may not have had any exposure to dialysis patients previously. Finally, I'd just like to mention the Buku Renal app that I'm leading on the development content for. This is a free smartphone app and is the newest addition to the Buku family. Buku Hematology was the first to be developed and has now been downloaded over 15,000 times internationally, and I'm hoping that Buku Renal will soon follow in its footsteps. The app provides free short tutorials and educational tips for a general medical audience. We are continuing to develop content, and I'm confident that this is going to be a fantastic educational resource, and I'd strongly encourage you all to follow us if you can. Thank you very much.
Okay, so thank you very much, Sarah. That was a great example of renal interdisciplinary simulation work that you've been doing in the department. Now I'm going to take you to another view, the view of somebody coming to train in the department and how their experience has been, and what they have learned whilst they spent some time with us. So Dr. Haroon Ayub travelled all the way from Pakistan to a foreign land such as the UK, and obviously spent some time with us through the COVID period as well. So he obviously was displaced from his natural environment, but I'm hoping that he will show how he felt and what he experienced as part of his year as an international fellow in interventional nephrology. So thank you very much, Haroon, for your talk.
Good afternoon, everybody. I'm Dr. Haroon Ayub, and I'm going to share my experience as an interventional nephrology fellow at Sunderland Diagnostic and Interventional Nephrology Unit. At the moment, I'm working as an assistant professor of nephrology in Pakistan, and I worked as an interventional nephrology fellow at Eston for about 15 months. So right from the start, interventional nephrology from east to west, right? So interventional nephrology is a developing field of renal medicine in Pakistan at the moment. Although renal medicine is more or less a developed field with a widespread network of renal centers and dialysis units in the country, and about many trained and experienced nephrologists in the country. There is a huge burden of renal patients in Pakistan with a high incidence of crash landers. So you can imagine with a high incidence of crash landers, there is a widespread use of temporary dialysis catheters. And as a result, there's a high incidence and high rates of strengthened venous stenosis and fistula problems and vascular access problems for these patients. So what are the renal procedures done by a renal physician in Pakistan? Mainly they include renal biopsies and temporary dialysis catheter insertions. Very few renal physicians, they're trained to pass tunnel dialysis catheter insertions. So that's all that a renal physician is trained to do in Pakistan. So the question arises that does Pakistan need intervention nephrology? Certainly, there's no doubt about it. With the emergence of crash landers and with the high incidence of central venous problems, Pakistan certainly needs a proper setup of interventional nephrology. Right. Now, my journey from Pakistan to Eston. So why did I choose interventional nephrology? I had an experience in renal medicine for about 5 to 6 years before I came to England for my fellowship. And this included a year as a renal consultant as well. So during my tenure, I had this feeling, and I saw many patients, and I came to know that Pakistan is lacking in the field of interventional nephrology, and there needs to be a proper setup and a proper center, where a patient can come and that center can provide all the facilities and services with regards to the renal procedures. Radiologists here are doing these procedures, but as you know, as it is throughout the world, radiologists are overburdened with the rest of the procedures as well. So the renal procedures do come down the list for them. So I chose RCP MTI route, and I'm really grateful for the Royal College that they gave me this opportunity to enhance my skills. So I'll just shortly and briefly describe how this works. So it is the Royal College of Physicians of London Medical Training Initiative. So I got in touch with Dr. Ahmed, who was my education supervisor, and he selected me, and I was selected by the trust as well for a post. So you need to have a trust post and an education supervisor before you can contact the RCP MTI, or it is the other way as well. So I followed that route, and then after that our RCP sponsors you, and it takes care of all the logistics, and which includes the GMC as well. So what was my baseline renal experience? So I had my MRCP and my fellowship in renal medicine, which is the FCPS nephrology, before I came to England, and I was working as a renal consultant for a year before I came. What were my baseline interventional skills? As I told you, most of the renal physicians here, they're just trained to do renal biopsy, they temporary dialysis catheter insertions, and that's all I had as, you know, my baseline skill when I came to England. Right, so what does it offer? So I'm not bragging about the institute because I've worked here, but I really mean it. It is a team of excellent and committed renal physicians and interventionists. And you know, this center, it offers a complete and comprehensive renal care to its patients. So once the patient enters the renal unit for its renal services, you know, the Eston, you know, it takes care of all the services that the patient needs, including all the intervention it needs. So it's done under one roof. And the procedures done at Sunderland are real-time ultrasound guided renal biopsies, temporary and tunnel dialysis catheter insertions. We pass different types of catheters, symmetrics ones, the barred ones, the Tesius ones, and also the Hickman lines and the PIC lines, and medical PD catheter insertions. And this procedure, you know, it just surged during the COVID era because, you know, we weren't able to get them placed surgically. So, you know, our team, it took the initiative and passed most of the catheters medically then. And Doppler scan of AVF and AV graft, and this comes under the roof of POCUS, central vein angioplasty and fibrin sheath disruption, you know, during tunnel catheter exchange. And of course, you know, the tip includes, you know, the fistulograms and the fistuloplasties. What was my experience at Eston? So this center, it's basically consultant-led. So, you know, it gives its registrars lots of opportunity to make decisions, you know, and interact with the patients, you know, and you get lots of procedures. But at the end, you know, it's the consultant who leads from the front. And it has a team of trained nurses who have immense experience in interventional nephrology. You know, Debbie and Carol, they are a real asset to the team. And this is my Eston family, and this is a cake on the very first day when I think so. It's September 2019 when Eston was officially launched. And the procedure that I've done during my fellowship, you know, it's just a brief review of my logbook that I've maintained. I did about 26 renal biopsies. These included native and renal, 16 PD catheter insertions, and 44 tunnel line insertions, 16 temporary vascular catheters, and about 40 POCUS scans. So Eston never stops to amaze you and surprise you. You know, this was my last day at Eston, you know, and we started this new technique of with the GoPro to, you know, just record our procedures while we're doing it. So it's an innovation in medical education. You know, you can record that procedure for medical education purposes, and it can be live streamed as well. You know, and you know, if you're doing a procedure in the fluoroscopy suite, somewhere persons sitting in a meeting room or a committee room, you know, they can just live stream and see the procedure. This was the procedure, you know. Due to the time constraints, I can't show you the whole procedure, but that's a snapshot of what we've done. This is the PD catheter insertion. As you can see, the needle is in the peritoneum and the dye, you know, it's just moving around the bowels. This is the guy inserted, serial dilatation, and that's the PD catheter being inserted. And that's the image of the patient with PD catheter being tunneled out and stretched. So from the procedures, you know, this is a poster that I presented at the Pakistan Society of Nephrology International meeting last year, in which, you know, we showed how ultrasound mapping for new cannulation sites of AVF, you know, a couple of research projects. You know, I did research on our pre-dialysis or LCC patients and showed what correlation did frailty and comorbidities have had on the outcome of pre-dialysis patients. And another audit in our patient at South Tyneside Hospital showed reduced mortality in AKI3 after nephrology in-reach services. This was the hardest part, I'll tell you, you know, saying goodbye to Eston. You know, I'm already missing them, and, you know, I miss Debbie's cake as well. So So now I'm starting my own interventional nephrology setup in Pakistan. I'm trying to gather a team of like-minded renal physicians, and I need, of course, a fluoroscopy suite, and I'm in continuous liaison with my team at ST as well for complicated cases.
Okay, so thank you very much for that talk, Haroon. I hope you had a great experience. Haroon has now returned back to Pakistan after the COVID pandemic and is now practicing in Lahore, Pakistan. So it gives me great pleasure to introduce the next speaker, Mr. James Gilbert. He is well known in vascular access, and he's one of the forerunning vascular access surgeons in the country working in Oxford. He's also our president of the Vascular Access Society of Britain and Ireland, and I've worked with him in a number of projects, and he is a real proponent for patient-centered care and vascular access, and he runs a number of programs for training as well in Oxford. So thank you very much, James, and we look forward to your talk.
A really good afternoon to you all, and thank you to the BRS for the invitation to contribute to this exciting webinar on interventional nephrology. I'm James Gilbert. I'm a transplant and access surgeon in Oxford, and I'm currently the president of VASB, and I've been asked to talk a little on what's new in vascular access. Here are my disclosures as I start. As we start considering what's new in access, I do think we should start with the blindingly obvious, and for me at this point in time, it's that of COVID-19 and its impact on vascular access services across the UK. Many services have had limited or no access to elective theatres. Major reductions in outpatient clinic opportunity, vein mapping services, radiological provisions have seen increased numbers of patients not get the access they would ideally have gotten pre the COVID pandemic. With increased numbers of crash landers or acute on chronic presenters, there's probably going to be an increase in catheter usage at first dialysis. We know these types of graphs all too well from previous registry reports, and we see year on year, don't we, the increasing numbers of patients on some form of renal replacement therapy, with transplantation and hemodialysis being the most common. I wonder if this graph will change dramatically over the next year or so. And what about this one? This is new starter data, where year on year we see around 30 to 40% of patients starting out on a dialysis catheter of some form. I wonder when we look at the 2019-2020 data in the fullness of time, we'll see a major shift of this towards the left, with increasing numbers of patients starting out on lines, something I'll come back to a little bit later in the talk. Of course, the COVID impact has meant that we need to think differently about how we deliver access, and it does require innovation and resourcefulness. And I know a number of centres have been looking into ways to provide new access opportunities for their patients. For us in Oxford, we've engaged with the private sector and set up contracts to outsource our NHS work to so-called COVID-cleaned sites. We do more virtual assessment clinic approach of clinic consult, mapping and surgery. Encouraging radiological and emergency surgical facilities to continue 24/7 in order to maintain access is critical, especially if we want to minimise line usage in our patients. And here are some of the sort of numbers we've managed to achieve over the past 6 months in terms of fistulas created, grafts inserted, transplants done in our patient cohort. As we move forward though, not only do we need to be innovative and resourcefulness with how we deliver a service, we need to embrace technologies that can minimise line, increase patency of access for patients once we've made them. And there are a whole range of new developments out there, some of which I want to talk about in the remainder of this presentation. I'm going to begin with endovascular fistula creation. This is incredibly exciting. There are at present 2 key devices on the market. There is the WaveLink system. This uses a 4 French catheter system that sees the placement of 2 catheters, one in the ulnar artery and one in the vena comitante or ulnar vein alongside the artery. Once the catheters have been placed, the wavelength device is inserted along each of the catheters, and these wavelength catheters contain magnets that attract to each other and pull the artery and the vein together. A radio frequency energy is then delivered to burn a hole between the two, thus creating an endovascular fistula that sees blood shunt into the ulnar vein through a deep perforator and into the superficial systems of the arm, arterializing the cephalic and the basilic systems, thereby creating an arteriovenous network in the arms that can then be used for needling for dialysis purposes. The other system is the ellipsis system. It works in a similar kind of fashion in that it's looking to join an artery and a vein together endovascularly, but it does it slightly differently. You undertake ultrasound guided needle puncture of your median cubital vein in the antecubital fossa and extend that needle down to the level where the radial artery is sitting adjacent. The needle is then passed into the artery through the vein wall and a guide wire is advanced, thereby having your guide wire go from vein into artery. A 6 French sheath is passed over the guide wire and into the radial artery. And once that sheath is in position, the ellipsis catheter system can be advanced through the sheath to enable the creation of the endovascular fistula. Once the ellipsis catheter is down and in position, the 6 French sheath is pulled back. The catheter is aligned so that its ends can capture the two walls of the artery and the vein. The catheter is pulled together and a hole created between the two to again create the endovascular fistula, thereby seeing flow shunt from artery into vein and into a superficial venous network. There's increasing amounts of literature out there about the outcomes of endo-AVF creation. I draw on this particular paper that was published last year, systematic review and meta-analysis, that looked at over 300 patients who'd undergone endo-AVF creation. And the upshot really is that the review has shown very favourable 6 and 12-month patencies of 91 and 88%. respectively, incredibly high patencies compared to those reported from surgical creation in the literature. I draw on this paper that was presented at VASB last year because I think this is a really important discussion point. This piece of work done by Nick Inston and his team looked at whether a surgical fistula should be created ahead of an endovascular fistula. And what they did there is they compared their cohort of wavelength created AVFs, which totaled around 30, and they compared them with a matched radiocephalic fistula group. And in short, what they found is that the primary patency at 6 and 12 months was greater in the group that had undergone wavelength fistula creation compared to surgical creation. And the question that's therefore thrown out is, if you have a patient that has borderline wrist options or even no option to create a fistula at the wrist, are you better going straight ahead with an endovascular fistula creation rather than trying to do a surgical one which is doomed to failure? New thinking, new approach, new opportunity in access. Moving on now to some other exciting new developments. I think the VASQ is something that's very exciting. We know whenever we create fistulas, we can have a problem with near intimal hyperplasia at the perianastomotic area and subsequent stenoses, and this is all to do with the flow dynamics and shear stresses exerted against the vein wall as blood shunts from the artery into the vein. Laminate Medical Technologies have come up with an external support device that allows the fistula vein to sit within this, and it contours the vein in a way that it maximizes laminar flow and maximal shear stresses to hopefully reduce the near intimal hyperplasia and stenosis that can occur. The way the VasQ is applied is you wrap it around the vein before you do your anastomosis. Once you've carried out your anastomosis, you then put an anchoring stitch on the back of the VasQ device just behind the artery, and it sits in position like so to maximize uniform flows from the artery into the fistula vein. A number of publications now around the outcomes of using this. The original publication showed that it was safe and efficacious to use, but more importantly, published last year in the American Journal of Kidney Disease, the results of a randomized controlled trial that had shown that functional patency at 6 months was significantly greater in a group treated with VasQ compared to a controlled group that did not have the VasQ device applied. Another exciting new development in access that I think could have major benefits to our patients in terms of improved functional patency going forward. Early cannulation grafts have been around for a little while. There's a number on the market, but they are of huge benefit to patients. They differ from standard grafts in the fact that they are trilaminates. They have 3 layers with a unique middle layer that is generally self-sealing and reduces weeping and blood strike through. The advantages being that they can enable early cannulation, usually within 24 hours of placement, and thereby could avoid the placement of lines, preserve venous real estate. Much of the literature now has shown that outcomes are comparable to standard grafts, and there are definitely lower infection rates and mortality compared to using lines. This slide shows the trilaminate nature of the graft in the top left, and you can see in the center at the top here electron microscopy images of a standard graft on the right and an early cannulation graft on the left that self-seals afterwards. This slide shows a patient 4 hours post-op receiving 2 needles for dialysis, having had a Flixene presented. And on the right side here, the benefits of using grafts in patients that crash land, thereby avoiding lines. A forearm loop graft has been placed here onto the veins at the elbow level. The upper arm basilic and cephalics have been arterialized, and these can then be used for fistula creation at some point in the future should they be needed, as was the case here. Something else that's new in access that I think is also very exciting going forward as we plan for our patients is the role of regional anaesthesia. This paper published by the Glasgow group in JASN this year has reported on an in-house randomised controlled trial looking at randomising patients undergoing radial or brachiocephalic fistula creation to either the procedure being done under regional anaesthetic or local anaesthetic. And the outcomes are pretty compelling, showing significantly improved primary and functional patency of a fistula if it was made under regional anaesthesia. And I think as access services get going again, this is something that we really need to be considering. Are we providing a system in which our patients can get the best possible results when they have their access created? I mentioned at the outset the impact of COVID and how many patients could end up on lines. And it's just worth reminding ourselves why lines are generally bad for you. They can do bad things on the outside, like get infected, but if they're doing things on the outside, they're usually doing things on the inside, whether it's thrombus at the tip that can cause occlusion or risks of PE, or the progressive damage that the line induces on the endothelial lining of the SVC and the innominate vein to lead to progressive stenosis, even occlusion of your central veins. And we know that when this happens and you try and create an access, you will run into huge difficulties with venous hypertension, as there's nowhere for that fistula flow to drain due to the occluded central system. And if you look at outcome data of placing a line in any of your central veins, you see that if you move to the left side, you've got a much higher annual stenosis or occlusion rate compared to if you go into the right internal jugular vein. But we will end up with patients like this, so we need options to get them out of trouble, and a couple of options include Hero and Surfacer. Starting with the Hero, this is a treatment option for patients who have central stenosis, enables them to have a fully subcutaneous arteriovenous access option that can offer reliable dialysis in the face of central venous disease. HERO consists of two components. There's an outflow component and a graft component. The venous outflow component is a braided nitinol stent that's completely covered with silicone. So you have an element of kink resistance because of the nitinol nature, and also crush resistance. Because of its silicone coating, you don't get any incorporation or ingrowth, and so you can actually take this stent out. It's therefore a customizable, sizable and removable stent for patients. It's placed into the right atrium through your stenosis or occlusion, therefore bypassing it, and then it joins a standard dialysis graft that's placed in the arm as you would conventionally for any access procedure, and the two are joined together with a unique titanium connector. It can be useful for decompressing pre-existing fistulas that are running into difficulty because of problems, pre-existing grafts. It has been evolved over the last couple of years to become the superhero, where that adapter, that coupler, has been manufactured individually, so you can attach one or two grafts of your choice onto the adapter and then connect that to. This slide here just shows a patient with a HERO graft in place, and you can see the long segment of needleable graft all the way up the arm and the outflow component disappearing into the neck. To the atrium. You'll remember from your anatomy that there's a straight line from the internal jugular all the way down to the groin region. And that from an anatomical perspective, the innominate vein, internal jugular vein and SVC confluence sits just behind the head of the clavicle. So anything anterior to this and above the head of the clavicle will come straight.
The Surfacer inside-out access catheter system is a novel approach to gaining venous access from the inside out. The operator navigates the Surfacer from the femoral vein and exits via the venous vasculature. A sheath is advanced over an O35 guide wire to the venous obstruction. It is the conduit for all instruments used during the procedure. After a target is placed on the exit area, the device is advanced into the obstruction. Fluoro is adjusted until the tip of the device is visible within the exit target. The device handle is rotated until the target window appears, and the needle guide is advanced out of the tip. The occlusion acts as a stabilizer as the needle wire pierces the skin at the predetermined exit point. The operator then inserts a sheath from the outside in. The Surfacer is removed, and a central venous catheter or dialysis catheter is placed using standard access procedures.
This is what the Surfacer looks like. It's about 1 meter long with a handle at one end. When you look at the handle close up, you can see there's a needle guide knob that when you rotate it, it advances a needle guide at the end, and then the plunger at the back end of the handle enables you to fire the wire out from within the Surfacer. It comes with a workstation, an exit target, and a peel away sheath. And the procedure is done as you saw in the animated video by getting up into the SVC from the groin, doing an O-gram to see your occlusion, which you can see here in this slide, placing the washer on the skin on the outside surface, and then advancing the surfacer up to the level of occlusion, pushing through the occlusion until you come to lie at the level of the washer, aligning the washer and the surfacer device to enable you to fire your wire from inside up and out through the skin. And just bringing things to an end, another exciting development to watch out for in Access is this. It's what I call the smartwatch for your AVF. It's made by Graphworks, but it's a special patch or transducer that sits across your fistula and can take all sorts of measurements and readings about your fistula, your renal status. It can pick up information around your access flows, whether they're going up or down over a 24-hour period, and can give you averages, so may well be way more accurate than current transonic machine readings done every month. This may be a really important thing going forward for our ongoing monitoring and maintenance of our access for our patients. And finally, the last thing I wanted to mention is the new KDOQI guidelines, which have recently been published. These are a really interesting read, and they're a paradigm shift of where we were years ago regarding our approach to access. They very much approach renal patients with a view that we need to develop individualised end-stage kidney disease life plans for all of them. And the mantra is very much that whatever we do, it's got to be right for our patient. It's got to be done at the right time and for the right reasons. Lots of exciting technologies to use, lots of toys to play with, all very exciting if you're an interventional nephrologist to get your hands on some of these, but we do need to make sure that we have services, systems in place that ensure that our patients get the very best access they can at the time they need it, in a timely fashion, and done all for the very right reasons.
Thank you very much for that excellent overview by James Gilbert. Now I'm going to switch to the Q&A section. Okay, thank you everyone. We are back online again. I've had to switch to another room as we have some technical difficulties. So the first question we're going to ask from our group and our panelists that we have is really, this is a bugbear question that comes on regularly in interventional nephrology, is about training. And obviously we're trying to develop the PG certification, so we need to bear this in mind. So regarding training, the question is the difference between nephrologists and radiologists who are best to do these procedures, and are we competent to do this training? I'm going to ask Shalabh Srivastava to take this question as part of the PG cert he's leading on. Shalabh, can you hear me, and can you take
Yes,
that question?
I can hear you, Sid. Thanks for asking the question. It's absolutely important to get the medical physics aspect of the training right. And in developing this upcoming postgraduate certificate course, what we've done is that we've used the pre-existing medical physics module in Newcastle University. So we are at very early stages of developing it, but hopefully we'll deliver it by next year, which will be hybrid of new modules for interventional nephrology and borrowing the medical physics module, which are pre-accredited for radiographers and radiologists who would want to do it. So we take away, we can't claim that, you know, we know it all. And there will be aspects of medical physics and radiology that need to be delivered by people who know best. And that is why we are using this hybrid model, especially in the upcoming year.
Right, so thank you very much for that, because as you alluded to and I alluded to in my talk, we are probably last to the party of interventional nephrology around the world, because other countries have overcome these issues, as you are alluding to in the PG certificate. So this is not new ground. We just need to take that learning forward. So I've got some great questions coming in from the Q&A box. I'll take them probably together first of all. First, generally about training and the training that is going to be available. So training at the level of registrars, really, either for procedures and courses that we want to do, and also for all the elements. So I can answer one of them myself, that unfortunately due to COVID, we did have a training program set up to go in March of this year, which was quite comprehensive, both from the lecture-based and also on the point-of-care ultrasound and the simulation, but unfortunately COVID got in the way. So we're very keen, and we've been trying actually even more recently to bring another point-of-care ultrasound course into Sunderland, but we just have to be cognizant of the environment. So as soon as the environment changes, we'll bring those courses for the trainees, especially with the new innovations that we want to bring through. The next question really is, Haroon, you're still on the line. I want you to take this one a little bit. The question from the Q&A box: is interventional nephrology a first world service, or is there a need to train nephrologists from the second and third world countries, or developing countries as we like to call them, who may be working alone without expert vascular surgeons? So Haroon, can you hear me? And the question to you is there a need in your particular part of the world?
Yeah, exactly. Yeah, I can hear you. Dr. Ahmed. Yeah, so definitely, that is the reason, I got in touch with you, and you're kind enough to bring me to England, and I travel round the corner next to round next to the world to get this training. So it's definitely the hour of the need of the hour, and in developing countries, if you don't have a proper intervention nephrology setup, so you just shuttling the patient from one corner to the other, to the radiologist and back there. And the patient does get mismanaged in this scenario. So I think so. Yeah. I think so. Even more than any place in the world, in the developing countries, a proper intervention nephrologist is required.
Okay, Haroon, thank you very much for that. Just to just recap on the previous answer that I gave regarding training, I'm going to bring that question to Dr. James Andrews, who is leading for us on the point of care ultrasound. So James, is going to just pop in onto my slide view here and take that question, please.
Hi, I just wanted to elaborate very quickly on a point that was made here regarding the point of care ultrasound courses. We're planning on running this free for our trainees in the region. If you want to have a free course, then I'd encourage you to come and train in the northeast of England with us. Otherwise, you'll have to pay. Thank you.
As you can see, we're socially distancing, so sorry I had to run out of the picture and come back in again. One of the things that the Renal Association, the BRS, has been really helpful with and encouraging us to develop such courses is the high-level engagement in societies. And obviously joining in with the Royal College of Radiologists will be important, and that is something we're looking forward to do, to really work out the pathways of care for our patients. We know that dedicated individuals who are into vascular access make a better impact on the patient's care as well. Now, going back to some of the questions in the previous chat box, I'm going to bring Dr. Clark in on this one. We always had to prove the point of the service being itself profitable, or at least safe and profitable. And that is a business case we had to write for the chief executive. And really the question is forward planning from either starting the service and then projecting forward to the number of patients we're going to work on, and do we still have the capacity? Because we've shown you a growth period over this period of time. That's probably related to the starting of the Essendon service that we led, but what is the growth in year 2 and 5, and what do we foresee as a potential capacity and demand issues? So Dr. Clark, would you like to answer that question?
So that's a quite complicated question to answer. I think the types of procedure will alter over time. So we will see the number of fistulograms go up. I think we'll see the number of ultrasound scans go up. I think we'll see a fall in tunnel dialysis catheters over time. That's the hope. And I think what's taken us by surprise a little bit is the rapid rise in PD catheter procedures. Now that's very much a local thing. So we were having the surgeons put almost all of our PD catheters in laparoscopically and left buried and then exposed when they were ready to use. And we've switched a little bit now so that anyone without a contraindication to local anaesthetic procedure has it done under local. So that's been given us a big swing towards Eston and those procedures. Ultimately, we have enough capacity at the moment. Some of the training that we're doing for our specialist nurses so that they will be able to do much more patient assessment work in a kind of nurse practitioner role, and be able to take over some of the ultrasound scanning and vein mapping and consent work, etc. I think they will be able to switch that work to the afternoon, meaning our morning sessions are left for procedures. And then ultimately we will need to business case an expansion of consultant time, particularly if we're able to form a hub and spoke model around the northeast to take referrals from other centres. And I think there's been some preliminary interest in that as well.
So thank you very much, Dr. Clark. A very good answer to that riposte there from me, actually, regarding being a manager. I always ask these kind of questions. So the second and third point that hits across these questions is safety. And then looking at safety in itself and building it into just pattern recognition and experiential learning that we all want to gain very quickly. People like me have been in the business over 10 years trying to learn this, but we can learn things much more quicker and more efficiently than just waiting around and doing lots of cases. And that brings me on to a question for Dr. McCloskey regarding the simulation training that we're doing. How does she feel that will run hand in hand with the procedures that we do?
Hello. So as you'll have heard from my talk earlier, we have a number of part task trainers which allow our trainees and anybody who rotates through our unit to get experience before they actually move on to performing the procedures on real patients. The beauty about having the 5-day Eston service, though, is that we have a huge volume of cases that we're able to expose our trainees to across the board. They're able to get excellent experience on things such as simple tunnel neckline insertion, vascular access, moving up to really complex cases where we're able to do angioplasty and angiograms of fistulas. So we're hoping that even despite coronavirus and the restrictions that it has on how we interact with patients and with each other, we're able to provide simulated training environment that will allow us to continue to expose our trainees to the type of training that they need in order to build their confidence. And, you know, in generally, it has been shown to reduce medical errors and also patient complications. So absolutely pivotal going forward that we keep up with our simulation training in order that our trainees get the experience that they need to be confident in doing this in real patients.
So, great. Thank you very much, Sarah, for that great answer to that question. It's, and I know Sarah's doing some great work, and it's not just in the nephrology department. Trainees in general medicine in all over the hospital have gained from the experience of simulation. So we do reach outside our own field as well to give other people confidence in learning new techniques and also regaining competency in what they need to do. Now, I'm going to bring a question to our VASB president, who I'm very privileged to have announced earlier on. So James Gilbert, I hope, is still on the line. And we know we have a VASB conference coming up later in October. And the question, James, is really regarding the combined working of a nephrologist and a vascular surgeon. Where do we sit together and where do we work together in this field? Because silo thinking obviously is where we used to be, but how do you feel working together has improved overall patient access and care?
You always ask some really difficult questions, don't you? And put people on the spot. But it is a great question. I think I'm very lucky that in my unit, I have a fabulous, strong multidisciplinary team where we recognise each other's strengths from a vascular access perspective. held the view that on the patient's journey, when a patient needs access, they get referred to the access surgeon, who sees, assesses the patient, makes decisions about what they think is right for the patient, but then discusses that with the patient's decision together. And I think that's really important for access to make by a nephrologist, but simply without conferring with them. So I think MD's clinical judgments, expertise, and coming from
So thank you very much to James. As expected, always a great answer from you and a good riposte to my difficult questions, as you state. Time's moving on. We actually passed the 6 o'clock mark. I'm going to bring this to a close after just one more question. And this is probably the key question that we need to push the ceiling on. It's between the unmet need of what the registrars and the training programs asks us and what we can't deliver on the curriculum at the moment, versus the tension as we're not trained to do those procedures, as we don't have those competencies. And this is where a PG certificate curriculum will come in. And as I alluded to in my talk, we're probably last to this position overall. So I think that will drive us forward to deliver our aim of a new certification in September 2021. And I've seen a lot of questions come in on the QA from the trainees themselves and also from the SPR club. So it's more of a comment by me than rather a question. But I think this kind of meeting has really highlighted that UK interventional nephrology is here to stay. It has really moved on in the last few years. And we are not only the primary moving unit, but there are many more like us in the country. And I think if we can work collaboratively together, we will succeed in producing interventional nephrology as here to stay curriculum for the future. So from me and from everywhere else in the team, it's goodbye. Have a safe journey home. Thank you for attending. And if you are still at work like me, I'm off to go and do some acute medicine. Thank you very much.